Welcome to the Coping Podcast, where we share strategies for coping with the stressors of life, especially the difficulties of parenting. And here is your host, Dr. Lee Weiss.
This is Dr. Lee Weiss. I am the host of the Coping Podcast, where I feature top experts on topics like raising healthy children, parenting, and so much more. Past guests include Dr. Doug Bolton, Dr. Ellie Leibowitz, clinicians Ben Kessler, Michelle Winterstein, Dr. Aaron Fromm, and many more.
Just a quick disclaimer, the information provided is for educational and informational purposes only. This is not intended to provide mental health treatment and does not constitute a client-therapist relationship. The information provided is not a replacement for being assessed and evaluated by a licensed professional and is not intended to replace mental health or medical advice.
This episode is brought to you by Coping Partners. Coping Partners is a mental health practice in the Chicago suburbs dedicated to helping children, adolescents, and adults. We help manage various challenges, including anxiety, divorce, behavioral issues, relationship problems, and much more. Please check out more episodes of our podcast and our website at copingpartners.com, and you can contact us with any questions you have. Before we dive into today's topic, I wanted to introduce today's guests, Jaime Monaco and Rivka Benjamin, who are the founders of Enso Wellness in Northbrook. Jaime is a dedicated child and adolescent therapist with over a decade of experience in mental health care. She specializes in CBT, space, parent coaching, and behavioral interventions. Jaime is passionate about helping kids build resilience through collaborative, wraparound support and works closely with families, schools, and providers to create lasting change. Rivka brings extensive experience working with children and adolescents across a wide range of challenges. Having a background in schools and mental health, she understands the unique intersection of academic, social, and emotional needs. As a mom of three, Rivka blends clinical expertise with real-world parenting wisdom. Known for her warmth, humor, and unwavering dedication, she creates a space where growth feels not only possible, but achievable. So today we will be learning about a wonderful PHP program in our community in Northbrook, and also talking more generally about what kids need when they're struggling, what types of interventions help most in these programs, and how parents can support the work that's being done. So thank you both so much for being here.
Thank you for having us. We're excited.
So, Rivka, I'm going to ask you to tell us a little bit about what inspired you both to start this program, and what gap did you see in mental health care that you really wanted to fill?
Yeah, so what inspired us is, first of all, both of us have a history in PHP levels of care and outpatient levels of care, and we both have a passion to help the children and adolescents, especially seeing post-COVID, the rise in all of these challenges, interacting with different people in the community and the parents. And the gaps we were really looking to fill were just making sure that the treatment they are getting, especially when they're in crisis mode, is really long lasting. So, the last thing we want to see is a parent in crisis getting their hopes up, they're back in school, and then they're back in PHP a couple months later. So a lot of what you'll hear from us is the way we design the program is to make sure that it's wraparound. We're collaborating with each and every person involved in the child's life and giving them the skills that they can use in different settings, different situations, and actually have it last longer than a couple months.
Mm-hmm. Yeah. Also, and Rivka says this all the time, we also saw a lot of wait lists. So there's still a need with how many PHP and IOP programs there are. We hated seeing kids sitting on wait lists. So on top of that, we just wanted to make sure no child, no family was left on a wait list while they're struggling, because, the times when you need PHP are pretty hard.
Absolutely. No, that's very true. And as the referral person, right, when kids are really in crisis, we do hear a lot of kids going to PHP programs, getting kind of, released back into the school setting and then having to return. So
Right.
What you shared, Rivka, really spoke to me that it is hard. Of course, the parents are eager to get their kids back into school and back into kind of real life. And yet you want to make sure that they're going to be set up for success.
Mm-hmm.
Yeah. So tell us a little bit more about the logistics, just again for more of the local community. Like, what networks are you guys in network for? In terms of insurance, what ages do you serve? Just a little bit.
You want me to take it?
Yeah.
We're a partial hospitalization program and an intensive outpatient program. We take kids 8 through 18. We will take as young as 6, case by case, just depending on we split our groups into 3 different age groups: children, teens, tweens, and teens. If our little kids group is more like 9, 10-year-olds, we'll kind of staff the cases of a 6, 7-year-old, but sometimes it's a little difficult just depending on maturity and how much they obtain from the group. But we do take 6 through 18. If they're 18, they still have to be in high school.
Okay.
Our PHP program runs Monday through Friday, 9 to 2. Our intensive outpatient program is our after school program that runs Monday through Thursday, and that's 3:15 to 6. We are in network with Blue Cross Blue Shield, Aetna, Cigna, and Optum. So the 4 big ones.
That's amazing. Okay. And again, that's huge.
Yeah.
So Rivka, I'm going to ask you to tell us a little bit more about what you were kind of alluding to in terms of making sure they're really prepared for success in the real world. In my view, again, I've never truthfully worked in a PHP or IOP program. So I give you guys a lot of credit. It's hard work. It's very intensive. But I always think about that environment as being like a nice, warm, safe bubble because the kids are really struggling and again, not able to continue in their school or home setting without much more support. So how do you sort of like prepare them while keeping them in this little cozy bubble?
Yeah, that's a good question. We do, we pride ourselves in being a warm, safe space in general. Our building, we're very colorful. We always have smiles on our faces. Our staff know all the children, all the parents. However, we try not to be too soft, too warm. So the way we handle it is, once they're engaged in programming or not, maybe just a little bit engaged in programming, comfortable with the staff. So I would say maximum 2-3 days because we do want them to get back. We do begin to expose them to their triggers in-house. So what we're talking about is, let's say a child is really adverse to writing. They cannot handle writing. That's when their explosions come out at school. We will begin to introduce them slowly, but they will begin to write 100% in the school group. And we will expose them and see how they react. So we can see what skills do they need? What skills do they have that are not working? And by the time they get back to school, they've been exposed to their triggers full time in a group of people with a teacher. We have a teacher who runs the school group, and they have learned how to manage it. So I guess you can add if you want to. So we're basically trying to expose them as much as we can here, see what's going on, and then send them back. Our biggest concern is the bubble. Are they coming here, getting away with all the schoolwork, kind of being like, yeah, I'll use deep breathing, see you later, and moving on. So we really want to make sure that they can actually use it operationally. And we're pretty stubborn. So we want to make sure they can actually use it, get through it before we try to expose them back into school.
Right.
And I love that because we do see some kids, again, historically, not from Enso, but they come back with these really cute like little infographics and they've memorized these strategies, right? Often CBT or DBT strategies, which we'll get into some of the meat of what you guys work on with the kids. But the question is, can they use it, right? Can they use it when they're flooded emotionally? And it sounds like what you're saying is maybe not day one. You want them to orient to the program and you do want them to feel comfortable because I'm sure it's a big shock to start one of these programs, but you don't wait too long. It sounds like to dip their toe in what triggers them and so that you can not only provide a skill hypothetically, but really in vivo.
Right. We definitely, so one of the big pieces too is a lot of kids will come in and be like, this is what triggers me. This is where I feel the most stressed or overwhelmed. And then we'll talk to schools and they'll be like, well, actually, yeah, writing triggers them. Showing the whole steps for math problems triggers them, where they will kind of withhold that information, whether they have insight into it or not, right? But we make sure that we're collaborating with school and outpatient providers to really get that feedback. So we're able to intentionally expose them to the triggers, and then even go a step further. Kids are very smart. as we're teaching the DBT and CBT skills in groups, they'll memorize them. They'll be like, oh, this is what I've learned. This is what works. So as we're exposing, if they've identified temperature change in DBT as a skill, we'll make sure when they're having, the anxiety attack, any external behaviors after being exposed to the triggers, encouraging them to use those skills and making sure that they're actually able to implement those skills in programming prior to sending them back to school. Then going even a step deeper, when they return back to school, we kind of set up school and the kiddo to make sure that if temperature change, having an ice pack, a warmie, whatever that may be, making sure that they have those things on them and know how to use them in that environment. So they're not, a lot of times they'll memorize all of these skills and program, go back to school and they're like, oh, wait, I don't think I put two and two together that my teacher isn't going to run down to the cafeteria and get a bag of ice. Absolutely. So we make sure that they have like breakable ice packs. The skills that they're learning here, we operationally teach them to use them in the situations that are triggering them as well.
I love that. So for people who are not as familiar with, some of these strategies, can you break down when you talk about temperature change as an intervention, like what is helpful about that? Kind of like really simplify it. And when would a kiddo need to use this kind of skill?
So temperature change, it's often a very popular one. It comes from the DBT skill tip. So there's 3 or 4. Sometimes they do TIPP, sometimes they do TIP, but it's temperature change, intense exercise, progressive muscle relaxation, or paced breathing. And so temperature change is a big one. TIP's a big one because I think it's just easy kind of to remember for the kiddos when they learn it here. But and so when they're like, oh, TIP helps, I'm like, right, but like what part of TIP helps? Because it's actually 3 or 4 coping skills. So and you can use this in multiple different ways. You can use a frozen orange where they can dig their hands into it. You can use an ice pack. It brings them back to the moment. It's used for mindfulness, grounding. If they're having a panic attack, it kind of shocks them out of their thoughts and brings them back into the moment where they're focusing then on the cold temperature versus whatever intense feeling that they're experiencing at the time of, stressful situations.
So can you give us an example of a kiddo in your program who was struggling with XYZ? You'll tell us what, and kind of like what was an intervention that you taught them and how did you operationalize, if I'm using that word correctly, how it was going to be implemented in the school setting when they returned. I'm using school, but it could be home or school.
Yeah, of course. Okay. I have 2 examples, but do you want to?
Okay. Yeah.
So there's 2 kiddos, and again, I'm going to use temperature changes because that's a big one.
And these are not real names, everybody who is listening, of course, but just we want to give you a sense of the work. Go ahead.
There was a kiddo who would experience severe anxiety, shortness of breath, could not concentrate, a lot of times would pace, was leaving the classroom often. If there was test anxiety, loud noises, anything that she perceived as, negative talk from teachers or students. But we would get her these ice packs that she would use when she would start to feel the onset of her warning signs. So we always teach the kiddos, you can't use it when you're at a 10. You're already too escalated when you're at a 10. You have to start using it when you start to feel the shortness of breath, start to feel the hotness or the, whatever your warning signs are when it comes to anxiety or externalizing behaviors. And so we really coached her when she was having anxiety. We would expose her to certain things in school that would make her anxiety rise. And she would practice using it in the classroom here. Then we would talk about, okay, we have ice bags here, right? What are you going to use at school? We bought her a pack. Parents bought her a pack of breakable ice packs. So when she was in her classroom, she had a breakable ice pack at her desk. So she would break it and then she would use it, on the onset of these warning signs, and it would help her from escalating all the way to a panic attack because she would, focus on the coldness, calm herself down, use breathing. So that's one piece. And
that one sounds like a kind of subtle, like if she could almost hide it under her desk.
Right. Because some kids, some do, but some kids don't really like standing out with their anxiety or mental health struggles at school. And so, we tend to, ask, like, do you feel comfortable with pulling this out at school? So there's a lot of different pieces that go into making sure that the skills transfer to the environments. Another example would be if the same kiddo I'll get into the deep breathing one in a second, but if the same kiddo identified temperature change as a way to alleviate anxiety, like you can't use that in dance or on the soccer field, right? You can't be like, I need an ice pack, I'm on the field playing. So it's like, what can you do in those moments that will help ground you when you're experiencing intense emotions, when you don't have access to tangible items? So then we'll talk about, distracting, 5, 4, 3, 2, 1, grounding, picking a color and making sure that you're looking for the color instead of thinking about whatever is making you anxious. So we kind of play out all of these different scenarios in the kiddo's life and make sure that the coping skills that they are identifying can be used in certain situations.
I love that. It's not like a classroom and they're passing the test and then they're never using this information.
Like, yeah, good luck.
Yeah.
Right.
And some things we'll do, some things we'll do with the younger kids, like I'm thinking of a specific 9-year-old, is have them decide, sometimes they'll name the skill themselves. So let's say the STOP skill is a whole great acronym, but he just took it as like, I need to stop, put my head down for a minute and then move on. Very externalized behavioral child. So for him, that was what worked for him. He called it the STOP skill. Was it exactly the 4 steps? No, but he knew that for himself. I will put my head down for a minute and then move on.
Yeah.
So I think it's helpful for them to like be able to like figure out what works for them, what they want to call it.
Well,
Right.
it's empowering too if they're able to name it for themselves and feel like that means something to them, right? Some of the names are a little bit,
Long. Yeah, they're long.
Yeah.
Sometimes the kiddos are.
Can you go back, Jamie, before I just don't want to get too far ahead? 5, 4, 3, 2, 1. When you're mentioning these skills, just again for the parents listening, what does that look like? Because I'm sure some of the parents are going to be like, oh, I can use that before Johnny melts down, tonight at home. Like, what would be an example of a 5, 4, 3, 2, 1?
Yeah, so 5, 4, 3, 2, 1. It's like 5 things you see, 4 things you can touch, 3 things that you can smell, feel.
Probably doesn't matter.
Everyone does it a little bit different.
Yeah. So it's basically just making sure that you're taking in the senses, bringing in the environment, and you're getting out of what's going on in.
Yeah. I was going to say, I'm sure there's a million iterations of it, but the concept of like, okay, this person is dysregulated, this kiddo, physiologically. And so it sounds like you're like trying to literally distract in a way to something, I feel this chair underneath my butt and it feels squishy or it feels hard or, the air is cool.
Yes.
See a red, whatever picture over there. So something to get them out of their inside world and more grounded. I love that.
Yeah. Something that you would taste, a lemon head, a Sour Patch Kid, something that
my mouth feels.
Yeah. A lot of people use Warheads, really sour.
Like a strong sour taste. I love that. Yeah. Very cool. Okay. No, this is super, super helpful. In deep breathing, did you guys have an example that you want to share?
Yeah, so I'll share that. It's
one of our favorites.
Yeah, one of our favorites. But before I get into that, I will say too, the biggest tip I have for parents is when they're helping co-regulate. So we're going to give an example where we would have to cope with the kiddo before they can do it independently. Is not to be. I always say the therapist. That's our job. We're the therapist. We can therapeutically talk to the kiddo. So when we train the parents on 5, 4, 3, 2, 1 or grounding techniques, we're teaching them to help them do it. So like, hey, why don't we look at 5 blue things that are around the room instead of the parents being like, hey, use 5, 4, 3, 2, 1, use grounding. So I think the kids get a little bit irritated with their parents when they are talking to therapeutically or trying to take on that role in the household. And we don't want them to feel the pressure to do that. So when we do coach the parents, it's coaching them on what the skill is and how to implement it in a comforting, supportive way versus, we're the annoying therapist that we are teaching them these skills. We want you to be able to be like, hey, you know what really helps? Like, let's breathe in. What can we smell right now? Oh, it smells like burning leaves. It's fall, something that they can do together so they feel supported and safe in that moment. And like parents know these skills too.
Absolutely. That's great advice. Again, parents appreciate all this like very concrete advice for what to do when they're really in the trenches. And kids, again, when kids are dysregulated, parents tend to feel dysregulated internally. It's hard not to. So like you're saying, if they have like sort of a go-to, what are they supposed to do? That's helpful too to them.
And we'll give them sometimes information like on skills because it is important for them to know it I feel like the kiddo gets more overwhelmed when you're like, practice tip or deep breathing, and you can't do it with them. So we always try to teach them some of the skills that the kiddos will identify as skills that help them. So they're able to co-regulate with them without, seeming to therapy.
Absolutely. I don't know, again, maybe Rivka, you can give us an example of a kiddo who had some of the more externalizing behaviors as the reason that they were in the program in the first place. Like why were they in the program? Like what were they doing in their home environment or school environment that was problematic? And maybe just again, like some of how you were able to help them practice in vivo, some by exposure, some of these tools so that they could be successful when they were kind of, again, discharged and starting back in their home or school environment.
Yeah, and the same thing comes to mind with the kid who would put his head down. So the behaviors at home and in school were very similar, difficulty being told what to do. It's a big one, especially things that were tough. So he was very, very smart. So writing out a full math problem was very difficult for him. He's like, I don't need to do that.
In his head.
Right, I can do it in my head. So some of basic compliance was very tough for him, and it turned into aggression at home. A lot of property destruction at school, need for the classroom to evacuate. So something that obviously wasn't sustainable anymore.
Yeah.
And when he came, he did math, he did writing, he did all the things he didn't want to do. Sometimes it was about simple compliance, like, hey, it's time to lift your head up. And that was very frustrating for him as well. So we taught him the two things that he renamed PMR, progressive muscle relaxation, where you kind of tighten your whole body and let go. And then we also introduced deep breathing. Now, deep breathing for most kids is very triggering. Like, do not tell me to breathe. And most of them are like, my mom's been telling me this my whole life. Shut up.
Yeah.
So we do coach them on, like, you get to choose which one you want, which one feels good in your body. And it was probably a couple weeks into treatment. His mom showed up. He had to go to an appointment that was very triggering for him. I don't remember if it was needles or something. And she told him, and he was very frustrated. This was one of his big triggers, and we were ready. We were prepared for a behavior to show up. And what did he do?
So, he got very tense. You could tell he was doing the progressive muscle relaxation, and then he would go. But mom was doing it with him. Like we were saying, we coached the parents. So I feel like in that moment, like mom started to do it, and he knew to take that cue from her. So then it was so cute. Literally no words, tensed up, started to do his deep breathing.
And he's like, let's go.
And he's like, okay, let's go. Yeah,
wow.
It was awesome. But I think, teaching parents those skills and having them have that cue, like, I got this with you, we can do this together. It was powerful. It was awesome.
Is that wonderful? Yeah. And just to go back to this kiddo you're describing, so he was destroying property in the school. Does that mean throwing chairs? Like, what would that look like?
Yeah, so throwing chairs, emptying marker bins,
ripping up books,
literally ensuring that the class could no longer learn. And he did do that here. When we exposed them,
what happens here if they do that?
So he did do that here. So the way Jamie and I set up the space is that there aren't many things on the wall for them to take down and hurt themselves or hurt others. And we don't look at that as like a bubble approach, but rather an opportunity for the behaviors to happen. He did make a mess multiple times. He's thrown chairs. We had to evacuate the room. However, at the end of the day, he was able to take responsibility, clean up after himself. We hold them to pretty strict, compliance standards here to teach them, this is how we take accountability. In school, this is what's going to happen. So he did destroy rooms. He was able to put them back together and utilize the skills. Wow. So they do go through the process. They don't come here and sit like angels.
Perfect angel in your and actually, I've been to your office, your setting, and it's so funny because it looks beautiful. Like, again, it's a very calming, like colorful, happy environment. But you've shown me, like there was definitely, like you said, there's nothing glass. There's nothing that if you shatter it, could be dangerous. So it's very thoughtful how you've designed the space to allow for some of these behaviors to show up. Because like you said, you want them to show up.
Yeah.
But it doesn't feel like, when I think in my head about a space where there would be like nothing just that could be destroyed, I think of like a a white hospital room with
Right.
everything on the walls that feels, what's the word?
Institutional.
Thank you. Yeah.
Yeah.
And it doesn't feel like that at all. So it's really neat to hear how you've really thought through like, what would the space need to look like? How would it need to be set up in order for us to be comfortable? Like you said, it's not that you want them to throw things, but you do want to see the behavior.
Of course. And I think the biggest advice to parents about behaviors and, it's going to get worse here before it gets better in any treatment. I think in therapy, it just always a lot comes out. And so it gets worse before it gets better. But it can be so scary as somebody that's been doing this for as long as I have been. And I'm one of, I feel like here we're have very high tolerance for behavior. So, and a lot of times it's still scary, right? Like, and you feel so bad that they're trying to communicate these feelings through this, type of communication. And so you want to coddle them, you want to give them what they want so they feel better. My biggest advice to parents would be to wait it out. Do not break the expectations. When your therapist is telling you specific steps, as hard as it is, wait out the behavior, let it happen, stick to the expectations without over accommodating because it will get better. But the more that you reinforce, it will stay in that stage of.
So just to make sure again that I'm understanding, you're saying like the kiddo who hates writing, if he throws a full-blown meltdown to like get out of writing, he can't imagine sitting down and doing it. You're saying obviously wait it out, let him have the meltdown. You're not going to stop it in the middle of it.
Right.
But at the end of the day, make sure that he has to still do the writing.
Yeah.
I don't know time-wise how long you wait, but at some point so that he knows that didn't actually earn him like a free pass.
Right.
100%.
Right. And in DBT, they call it shaping. So it's really just ignoring the negative behaviors in a supportive way. You're not just going to turn and act like you're not there for them, right? You're sitting there while they're destroying the room. You're still setting the expectations, but they still have to do the unpreferred task. They still have to clean it up, or, they're not going to get the preferred activity. If they don't do the unpreferred activity, they don't get their preferred activity. So it's hard though, when they're struggling that bad and the behaviors are becoming, increasingly more acute. You want to be like, okay, fine. You don't have to do the writing. It's okay. We understand, but they're never going to build that tolerance if you don't, make sure that you're waiting it out, especially during a time like PHP or when they're in a higher level of care.
Right.
And we're here for the parents, obviously we're coaching them and we're like, you gotta just wait it out. But we also are here for them understanding it's scary. It could be embarrassing. Parents are often apologizing to us and we're like,
No big
we're
deal.
the people to apologize to. So we do a lot of like hand-holding for the parents where this is very painful. This is very scary. And we're going to be here every step of the way to help you get through it.
Which is beautiful because again, parents, it's funny, they do the same thing with us in outpatient. They'll say like, I'm so sorry you saw that side of her today, and I'm like, no, like it took a while to build rapport to get to this point where we can really see like the true struggles. That means she's comfortable. That's a good thing. And now we can work with it. Whereas otherwise they're like saying, oh, everything's good. Like you're not going to do the work. So
Exactly.
yeah. And for you guys, it's like intensified version of that, I think.
Right.
Yeah.
You talked to our practice, and it was again really helpful about, how you teach foundational skills before jumping into the higher level, like DBT and CBT, which I'm going to just share for the listeners. CBT is cognitive behavioral therapy. DBT is
Dialectical.
I'm like, I never pronounce it right. Dialectical therapy. Thank you. Tell us a little bit about what does that mean, the foundational skills?
So there's a couple things. Do you want to touch on this or do you want me to? Okay. So there's a lot of like modalities that kind of like spin-offs of the, the original ones, which is DBT, CBT, especially in short-term care. So there's RODBT, there's exposure CBT. There's a lot of like different kinds that kind of go off of these two. And I think in order, especially for kids that are coming in first time in treatment, sometimes they're not, but for kiddos that are young or it's their first time, we want to teach them the basic CBT and DBT skills. Even when they're a little bit younger, you're not going to teach them a whole acronym in DBT because they're never going to remember it. So like if you just have to start with one basic skill and make sure that they're really understanding that, I think that is more effective than jumping and going to this, new age modality that's a little different than CBT, a little bit more complex, but the kids are like, what? I don't even know what the CBT triangle is, right? So I think that's really important is we're not reinventing the wheel. We just want to make sure that they're getting the most effective, scientifically based skills. And it always starts with the basics of that. And then we just build off of that. If they're coming back for their sixth time in treatment and it's a little bit more of a complex kid, then we'll, try different modalities. But it's really important to always start with making sure that they understand what has worked for years, which is the basics of CBT and DBT.
And for the younger ones, we often even strip it back further, as simple as how to be a good friend. What do I want in a friend? What does it feel to get super angry? How does my face feel? So we often strip it back even further before the skills to like have them build some type of awareness of what's going on around them.
I was just going to say, it seems like for the younger ones, just even being able to name, like Jamie, you were saying earlier, what does it feel like in your body when you're getting anxious or when you're getting mad? Like they have to be able to identify that before they're in a full-blown meltdown.
Right.
And for little kids, that's pretty hard. Yeah. So naming,
it is.
feeling, what are their signs? What are their triggers? Like you guys rattle that off like no big deal. I think that's hard work for these kids.
Really hard, especially for an 8-year-old. Like sometimes I don't even know my own morning sign. So it's like for an 8-year-old, how are they supposed to be like, oh, my body feels hot when I get mad? Because all they're focusing on is the negative feeling.
Right.
So it's really important for them.
Right. Absolutely. Tell us a little bit. I know you both, again, because I've gotten the pleasure of collaborating with you. I know you're both incredibly collaborative individuals. That's how you work. But tell us about how this makes the work you do in the PHP and the IOP programs so much more productive. Like, how does it look like when you collaborate with the child's school, parents, potentially psychiatrists? Like, how does that help the work?
Yeah, so when they first come in, that's one of the first things we do because this is a short-term level of care. And I'll keep repeating myself, we're not kicking them out, but we do want them to be able to get back to their daily life. When we speak to school outpatient providers, the psychiatrist always touches base with the psychiatrist. And sometimes they'll even have like a PCP who knows them well, or like someone who just did their neuropsych testing. We get to see different perspectives. So like here's how he acts with someone he knew for a long time. Here's how he acts for someone he knew with someone he knew for a short time. School setting, home setting, in the store. So collaborating with everyone, including parents. Parents, we go through a very detailed list about what their entire day looks like. So we're gathering a lot of information so we don't have to pick up the pieces ourselves. Every single piece ourselves, and then we'll probably see a fourth side to things. So it really helps us like jumpstart treatment where we can create a treatment plan that will make sense for them.
Right. It's really helpful too, I've noticed in the transition back to school. So like we gather all of that information in the beginning. We kind of leave it up to the schools and outpatient providers on how often they want to touch base because we kind of let them take the lead even when they're in PHP because that's their kiddo. They've had that, for years and we're just a short term, 6 to 12 week level of care. So
and that's actually interesting because some therapists I've spoken to really want to like have a touch point more frequently and others are like,
don't call me. Yeah.
Not in a bad way, but like I'm letting them do their thing.
You're right.
And I'm really eager to hear like what the discharge recommendations are. So every therapist handles it a little differently, but it sounds like you're flexible individuals and you're willing to kind of meet the other practitioners where they're at too.
100%. And it becomes very helpful because when they're going back to school or when they're transitioning out of program, we'll have a meeting with everybody on the meeting call, outpatient provider, school, psychiatrists don't usually, but are more than welcome to join. And then Enso and the parents, and we all get on the same page. This is the plan. This is what works. This is what doesn't. They're free to ask questions. The school then and the outpatient provider can coordinate for when they're taking over a little bit. So we love to make sure that when they're transitioning out, there's nothing left unplanned. Even in school exposure days, it's like, are they taking meds at Enso or at school during their half day exposure? Where are they eating lunch? Like every single thing is planned out because that is just going to help things go so much smoother. In IOP, though, I just have to mention this. We will taper them off. Like we will coach parents on like how to take over that planning, and how not to over accommodate. But we make sure on our end that treatment is done with everybody to just the little details that sometimes are like he didn't eat lunch in either spot. Now he's, regressing or whatever it may be. We just try to set them up for success as much as possible with everybody involved.
I love that. I love that. Jamie, you use the word accommodate, and I know you're space trained. So just thinking about, again, the parents and what they can do to help when their kids are really struggling, what they can do and what they shouldn't do. Can you tell us a little bit about what you mean when you talk about accommodation and what that could look like? Give a couple examples.
Yeah. So accommodation often is when, again, parents are seeing their kid struggling and they want to make them feel better. That's their kid, they're in crisis. So they will, if the kiddo wants to sleep with parents because they're scared at night, they let them sleep in their bed. Or when they're having anxiety about going to an after school activity or school, the parents will be like, okay, today you don't have to go, you can sit home and, take a break today, take a mental health day. They're over accommodating. They're making them feel so comfortable with these emotions that, if the kiddo knows they have an exit plan, they're going to use the exit plan. As an adult, if I know I can like get out of something a little bit, I will do it, right? We're all human. So I think my biggest advice to parents is supporting while they're supporting their kid, making sure that the expectation of what they need to do is being held. And giving them the independence and the, what's the word I'm looking for? Courage or confidence to use skills and know that they can do it. The more we take away when a kiddo is feeling big emotions about something, the less tolerance they have in that specific situation. So I always say, like, maybe if they're in crisis and we have to stabilize them first, we can, temporarily take something out. But if a kid's just having anxiety about school, like making sure they're still being held to the expectation and for a while just being there as a support, having them cope independently, not over accommodating where they're meeting this kid and making everything so easy. Because in the real world and as they're, growing up, it's not going to be easy for them. It's going to be harder eventually. So I think just making sure they're building that tolerance because it will get easier. They just have to learn the skills. And if you over accommodate for them, they're going to be stuck in the cycle.
And sometimes they come to us, they have already over accommodated. We give them like a log, so we do walk them through step by step how to decrease the accommodation while increasing the support. So it's not like we're like, take it all away, set them up. We're really doing it step by step. And we also educate the parents on how anxiety works. So anxiety loves control. It feels really good. And once you're giving them what they need, they're going to constantly need more control, which is making their anxiety worse. So we educate them on how it's actually not helping their anxiety. So we try to give the parents a glimpse into what's going on in their minds instead of just being like, yo, stop that.
Yeah.
So,
No, psychoeducation, some support for the parents too, because again, anyone who's parented knows in the heat of the moment, it's hard to like separate what is happening, the logical parts from the emotional parts. You're swept into it. And so for you to break it down and like have them chart where are the biggest meltdowns happening, what are the triggers, and to really unpack what are you doing, what are you not doing. It sounds like you really are helping them too.
I mean, it's the biggest part because the kiddo, they're one piece of the puzzle and the supports all have to be on the same page in order for it to work. So that's why we're so big on collaborating is that it takes a village. They need, everybody. So.
Absolutely. So I'd love if you want either of you to share like maybe one or two more cases just to kind of share an example of, again, a presenting issue of why a kiddo came into the program, some of the skills, and kind of how it worked when they were, again, discharged. And then we'll let you speak about anything else that you want parents to know before we wrap up.
Yeah. One thing I will say, I'm going to give a case example about that how we're trying not to provide such a therapeutic environment here, and we're trying to make it very realistic so they're exposed to certain triggers. So a lot of questions that we get asked by parents is, do you have different tracks? Do you have, a group for externalizing kids? Do you have a group for internalizing kids? And oftentimes we're met with some concern because we don't. We have them, our groups are 8 to 10.
It's age-based.
Right? It's age-based. but it's not behavior based or presenting problem based. So a lot of parents will be like, well, I don't want my, she has anxiety. I don't want her with the kiddo that's destroying the classroom. Or what if they pick up different symptoms?
Yes.
That is often a fear, which is completely valid. But what Rivka has said is there are no tracks in life. And so they are going to experience this in classrooms, at work, on teams. And so it's important for them to be exposed to this and then be able to cope.
Mm-hmm.
With this example, we had two kiddos. One had severe anxiety, very internalizing. When she would get anxiety, put up her hood, head down, wouldn't talk. The other kiddo, when he was having anxiety, was more externalizing, throwing stuff, name calling to kids. Her biggest fear was being called a crybaby. She gets called a crybaby at school. And so in group,
He picked up on it.
he picked up on it, didn't know that crybaby was the term that she was fearful of, said crybaby. And me and Rivka weren't like, yes, it's happening, but we're like, okay, like she was exposed to a real life situation that she's scared of. She was able to, not at first, but eventually get a set of skills to help use when because this kiddo picked up on it right away. Like the minute that he said it the first time, he knew it bothered her and would say it every time he was having a behavior, right? So, but she eventually was able to like have this confidence, use opposite action was a big one where when she was feeling like she wanted to cry, she would like stand really straight, would try to act really confident. So it would kind of push those tears down.
Wow.
Also, though, the kiddo, then we had to have a conversation with him and he learned how to apologize. He eventually, like they talked it out and they would help each other in group. So I think it's really powerful when there are real life situations that they're going to face and they're not in this therapeutic bubble of, all anxiety kids and all externalizing behaviors.
All being polite to each other and tiptoe.
Right. Yeah.
I mean, they could be in Trader Joe's having a meltdown and a kid walks by and says, "Hey, crybaby."
Right.
He can't control that.
He can't control that. So we kind of it's very therapeutic, but we love when those situations happen because it's like, yes, this is exactly what we want them to be exposed to things here because we want to see how they handle it. And obviously we have conversations with the parents, like we can't just be like, sorry, and we'll explain how we manage that therapeutically in group. But that's just an example of why it's so powerful to have this mix of kids because in real life, there's going to be a classroom full of, different kind of personalities and diagnosis, and you can never control what's going to happen outside of here. So
it's interesting when we talk about exposure. One of the things that comes up sometimes with some of my clients who are more perfectionistic, like straight A student, is they'll be so worried about, well, what if I don't get an A, on a test or in a class? And the problem is most of the kids who have those fears have really never had a B or a B plus even, right? And so there's no like schema in their mind of, well, it happened. It wasn't my favorite feeling in the world, but basically I handled it and the world went on. They don't have that notion because it's never happened. So they really have these fears, like if that ever happened, the world would crumble, my life would not go on, So we talk sometimes about imaginal exposures and just, I can't make you get a B, but I want you to at least think about what would it feel like if you got your test back and in big letters it said B instead of A, what would it feel like in your body? And it sounds like what you're saying is, this is even better, right? Not only can we imagine that someone's calling this girl a crybaby, right, before she goes back out into the school, but it actually happens.
Yeah.
So, and it's not like you would have ever set that up and told the boy to call her a crybaby. That we would have some issues with.
Right.
But I love what you're saying that like because of the mixed nature of this group, that organically happened. So
and I think it also goes back to like parents wanting to over accommodate their kids and be like, I only want them with the anxious kiddos. And it's like, well, it's a good thing if they experience certain situations because they're then going to be prepared in the future to handle them. So it always, goes back to that psychoeducation piece.
Absolutely. Oh, what a great example. Thank you, Jamie, for that.
Yeah.
Rivka, any other examples that you want to share again before we kind of wrap up? This is so enlightening.
That's a good question.
Social anxiety, I keep thinking about, or school refusal, like some of the ones that come up a lot in terms of, in my mind, what would cause someone to go to a PHP or an IOP program.
Right. With social anxiety is such an interesting one. It could be in the range of ages, but what's interesting about it is something we really try is that all the staff understand everyone's treatment plans. So if they make a mistake, they should be okay in groups and how to handle it. So although we don't try to plan someone calling someone a crybaby, sometimes we will plan, having the therapist call on a kid who didn't want to raise their hand and try to have them work through it. Again, we're pretty sensitive people, so we're not throwing it at them. But sometimes it really gives them the confidence and they're like, wait, that wasn't that bad. I answered the question and I was okay. Absolutely. So social anxiety is always extremely interesting to me. I always enjoy that. And then sometimes even the OCD, a lot of times that's in the older kids, germ OCD, I forget what it's called, or germ OCD. So, a kid it's wintertime. I mean, now we're blowing our noses all over the place. So a child is in the teen group, doesn't want to have a big behavior because it's embarrassing. This kid is 15. Right. And people are continuously blowing their noses. Those are great exposures. Again, you're in Trader Joe's is my favorite store. So you're in Trader Joe's and a person's blowing their nose. That's a great exposure to be like, you can't look at them and be like, you shut up. I don't want to hear you blow your nose. So those are always fun ways to see how naturally it will happen. And if we have to plant a little here and there, we will, but we're not evil.
No, I appreciate the setups, which is different than the we're going to traumatize you now by calling you a horrible name, right? That's a little
Exactly. But no, we won't involve other kids. We won't have other kids set up the exposure.
But no, I think about law school where they cold call people and you have to be able to. It's not no one likes the feeling. I mean, I don't know anyone who says I really want to be called on when I'm prepared and don't feel like I know the answer. I don't think anyone would say that, but there's a difference between being uncomfortable and being able to handle it and feeling like I can't even go to the class because what if it happens and what if I'm embarrassed? What if I have the wrong answer? That it's just taking a toll on their functioning.
Right.
Yeah. Yeah.
We try to eliminate breaks here, taking breaks also, just because I know at school sometimes they get passes if they get anxious, and so we'll try to have them do in the group room skills that they can use at the table, because I just feel like breaks are so, it causes so much more anxiety because then they're missing classes, then they're anxious about what they missed.
And then people noticing how often they leave.
Right. Yeah. People noticing. So that's another thing too with socially anxious kids. We try, or, anybody really, but we try to eliminate some of the breaks. In the beginning we'll allow it, but then we taper them off because it's just not beneficial when needed. This is not all.
If it's an emergency and they're, about to go, I get it.
Right.
It's a last resort, it sounds like.
And if it's, let's say, a child who comes in with an elopement issue who walks out of the room, we encourage breaks, but we encourage them to ask first. And once they got it down pat how to ask before they leave, then we say, hey, maybe we'll delay the breaks or maybe we'll taper it down. So it's really case by case, child by child.
It's so individualized. You can tell that you are really passionate about this work, and it is not a cookie cutter, one size fits all. We're very glad that you're in our community. Very lucky. So as we kind of end the podcast, what do you think parents would like in terms of resources if they're interested in learning more about, again, their role, how they can help their kids when they're really struggling to this degree? It could be a podcast, a book, a website, any resources you recommend?
I love Breaking Free of Child Anxiety and OCD by Eli Leibowitz. It really shows space and how not to accommodate and how to organize, how to start with certain accommodations. That's a big one. There's a lot of good children's books. Actually, Gabby, one of our therapists, does book reviews on our Instagram and our LinkedIn. And so we constantly have different books that are helpful for kids, parents, teachers. She posts that. So that's really awesome.
Amazing. Okay, so Instagram, do we just look up Enso Wellness Centers?
And Enso Wellness Centers. And then,
Same with LinkedIn.
Okay, amazing. Well, thank you both so much for sharing your time and expertise with us. It's been such a pleasure to learn from you.
Thank you.
It was such a pleasure. Yeah, we were excited.
Oh, and thank you. And everyone, please check out more episodes of our podcast. Please go to copingpartners.com and click on podcast and articles. And thank you as always for tuning in.
Thank you for listening to the Coping Podcast. We'll see you again next time, and be sure to click subscribe to get future episodes. And check out our podcast page at copingpartners.com.